This video looks at the dry needling for the trapezius muscle. Innervated by the accessory nerve, the upper fibres of trapezius can refer pain ipsilaterally from the posterolateral region of the upper trapezius to the temporal and mastoid area. Trigger point activity in the middle fibres of trapezius can refer pain into the interscapular region and out towards the acromion process. Trigger points in the lower fibres of trapezius may refer pain to the posterior cervical and mastoid region, out towards the acromion process, with some spillover into the interscapular region. With the patient in the prone position, this muscle should be needled in a posterior to anterior direction. Pneumothorax, as a result of the needle penetrating the lung, is probably the most serious adverse event possible in the area. To minimise this risk, the needle insertion or any needle manipulation should be done with a pincer grip palpation of the muscle belly. The anterior and more medial trigger points should be needled in a posterior to anterior direction. The more lateral trigger point should be needled in a posterior to anterior and cephalad direction. With the patient again in a prone position, with the arm resting by the side, the trigger point taut bands in the lower fibres of trapezius can be palpated for. The area can then be needled at an acute chordad angle. This superficial method should again reduce the risk of pneumothorax. Taut bands in the mid-fibres of trapezius should be palpated for and secured with middle and index fingers over a rib. The area should then be needled in a medial to lateral direction at an acute angle towards the spine of scapula.